All right, so welcome to the webinar hosted by the National Center for Healthcare Leadership on NCHL's Health Leadership Competency Model. By way of introduction, my name is Melanie Standish, and I'm the project analyst of the National Center for Healthcare Leadership, and I primarily work with our Leadership Excellence Network. Prior to my current role, I worked as a project coordinator for the revision and validation of the current 3.0 model. So I'm very excited to give an overview of this model today and to address any questions that our webinar audience might have. Any questions that I cannot answer today, I'm happy to take offline following the webinar. And just so we all know, the call will be recorded and posted to our public YouTube channel for anyone interested in sharing this presentation or viewing it again after the call. Just a brief agenda of what we'll be going over today. First of all, what is NCHL? What is the history of our Health Leadership Competency Model? I'll go over the process of revising and revalidating the model, as that was done very recently, an overview of the 3.0 model, and then some tips and tricks for how to utilize the 3.0 model in your organization if that's something you're interested in starting. So what is the National Center for Healthcare Leadership? We are a not-for-profit organization that works to ensure that high-quality, relevant, and accountable leadership is available to meet the needs of 21st century healthcare. So we're really interested in looking at the evidence base around leadership development and what we can do to improve that space. So why leadership development? Well, when we think about leadership development and how we can use it to move healthcare forward, we generally get something like this. Governance comes up with a strategy, and then strategy goes into execution. Boom, that's it, right? We get our outcomes, and then we're all set to go. Well, that often doesn't happen that way. What ends up happening is that we have a series of programs that are implemented to try and execute this strategy, and it doesn't necessarily go as planned, and people start reporting that it's very confusing. There's too many things on their plate that are going on, and no one really knows what anyone's talking about more and how they should be developing themselves as leaders. So at NCHL, we really look for moving from this to something like this, where we have a strategy, and then we choose to map it to a set of competencies or a series of knowledge, skills, and abilities that makes an effective leader. We use those competencies to map to development initiatives. So we say, okay, this person needs to develop as a leader. What are their current gaps and what can we strengthen? And that's how we get to our outcomes. And hopefully when we're trying to get to those outcomes, this is all underlined by a great talent management system that at the same time is attracting and hiring amazing employees that are hopefully geared up for succession planning to be future leaders. And so what NCHL really focuses on first is the what of leadership. We can take a look at the competencies themselves. And so our 3.0 competency model is what we currently release to the public, and the free competency guide that you can access through our website. We'll fill out a brief survey if you don't have it already, and we'll be able to send you a copy. And so it's sort of our gift to the field so that we can promote evidence-based practice and competency modeling. And then if competencies are the what, development is the how, and something that we do at NCHL is release the annual or the biannual National Leadership Survey, which informs our best organizations for leadership development. And this is an evidence-based survey where organizations can benchmark their leadership development practices against other organizations. And this is going to be launched again in 2020, so if your organization is interested in filling this out, feel free to check out our website, and more announcements will come sometime around April next year. So how do we do all of this? Well, at the National Center for Healthcare Leadership, we work on strengthening healthcare leadership. This is done through our competency model in addition to collaboratives like the National Council on Administrative Fellowship. We also look to strengthen our leadership development systems, which, as I mentioned before, is done through our Best Organizations for Leadership Development initiative. And we also work on strengthening U.S. contributions globally through our U.S. Cooperative for International Patient Program. And overall, we're really just looking to give back to the field and strengthen the science around management and leadership research. So when it comes to our model, I always like to say that all models are not created equal. So what makes our competency model different than other models? Well, in the current state of practice in the healthcare sector, competency models are not evolved based on recent leadership literature and are typically profession specific, meaning they only apply to a small group within the healthcare sector. And they're often evolved via two approaches that don't bring us to a good definition of effective leadership. First, you have something like the individual approach, where a person says, you know, I've been a really effective leader. I'm going to come up with the knowledge, skills, and abilities myself that I think make effective leadership. Or the second is the consensus approach, where a group of people get together, most likely executives, they talk about what leadership means to them, and then they decide on a set of competencies they think that everyone else should live up to. And when we look at a hierarchy of evidence, this really falls to the bottom. We're not doing this in a methodological way, and it doesn't necessarily get at all healthcare leaders at all levels of an organization. And so with NCHL's model, it really establishes core competencies for health leaders at all levels of the career cycle. And it also strengthens the practice of health leaders with academic research. So a brief history of the model. Model 2.1 was developed sometime in 2005. The model began and was released around the time of 2007. And so that originally existed with 26 competencies in 3 domains. And this was developed with Hay Group at the time and went through rigorous behavioral event interviewing, where we interviewed around, I would say, 200 leaders, high performing and mid performing, to determine what competencies really distinguished great healthcare leadership. And so from there, what the state of research tells us is that competency models should be revised and revisited about every 5 years. So when we decided to take this project on in 2017, at that time, it was definitely well needed, and we are really excited to release this model as of 2018, and I'm really excited to go over it with you all today. So why should we revise and revalidate? Well, first, we want to capitalize on current and emerging research on leadership competencies. And so since the model was released in 2007, the Society for Industrial and Organizational Psychologists actually released a PSYOP task force that talked about the current state of competency modeling and how they should be developed. And so a lot of this research for the 3.0 model was based upon that. We also want to incorporate current and emerging challenges and opportunities anticipated for the health sector in the coming decade. And so what we really did was take a look at what will healthcare look like in 2030 and what competencies will leaders need at that point in time. Because the important thing about competency models is not just preparing leaders for something right now, but what they're going to need in the future. And finally, we wanted to pursue a more inclusive definition of the leadership role. So in part of this research, we really wanted to define leadership as accomplishing shared objectives. So you didn't just have to be in a leadership role to be defined as a leader, but you could be someone in your organization who is seen as a leader. So I'll briefly go over the phases of the model's development. We did publish an article in Healthcare Management Review if anyone is interested in reading the full validation of this competency model. But we pursued the development of the 3.0 model first through a future scan. So as I said, it's important to look at what leaders are going to need in the future. So we used 2030 as a reference point, and we asked, what is leadership in healthcare going to look like at that point, and what competencies might leaders need at that point in time? Then we conducted leader role analyses, and so this involved behavioral event interviewing, where we asked a series of healthcare leaders that are high performing and mid performing what their daily leadership roles look like and what competencies are exhibited and what they're talking about. And so that way we're able to distinguish what a high performing versus a mid-level performing leader is doing in their everyday work. We then went through an assessment of generalizability, and so with that we sent out the competencies that we were able to distinguish from the first 2 steps out to the field, and they were able to say, yes, this competency is something that's important to healthcare, or no. All of the competencies that we released through that survey were approved for the model and met the threshold that we had set. And then finally, we cross-mapped our competency model to other health sector leadership models. So as part of developing this model, we wanted to make sure that it had similar competencies that other areas of healthcare were using. So we used a competency model from the nursing sector, one for clinicians, one for social workers, to really try to bring together all areas of healthcare and make sure that we were very inclusive in the competencies that we were using. And so as a result of that, these are the main changes from Model 2.1 to 3.0. We went from 3 to 7 domains, and I'll go over this in more detail because the primary changes within this competency model was mostly in the structure of the model itself and not necessarily the competencies. And so it was a lot of reorganizing of existing competencies and not a lot of adding of competencies. So I will talk about the 2 that were added. We also went from 26 to 28 competencies. So communication was a competency in our 2.1 model that is now broken down into 2 competencies, a writing competency and a speaking and facilitating competency. And then we also added our well-being competency, which I'll talk more later. And this was really one of those emerging areas that we felt needed to be included in this model after conducting our future scan. We also updated language in some of the behavioral statements, and so we made any tweaks if they didn't make sense or needed to be parsed down a little bit to give better understanding. And we did eliminate some of the proficiency levels in 2 of the competencies, and in those cases they were either combined to be more concise or they didn't show up in our behavioral event interviews as an area that needed to be kept, and so they were eliminated. So essentially, our model went from looking like this with our transformation, execution, and relations domain, which was previously called our people domain, and it went to this. And so this is our full model with all 7 domains. And really, you can take a look at this model by looking at the different levels of specificity within the model. So you can take a look at our full model, which you saw on the previous slide. And then if you want to get specific, you go into our broad domains, which I'll go over, which are our action domains and our enabling domains, which is a new addition to the model. You then get into the individual competency domains, which houses the competencies. And then once you get down to the individual competency, you can look at the different proficiency levels within the competencies, which individuals can take a look at, okay, do I exhibit this competency, and at what level am I at in exhibiting that leadership competency? So this is the current state of our model, and I'm going to talk about the action competency domains and the enabling competency domains, which are our broad domains. So with our action competency domains, these describe leaders in the context of doing their work. So this includes the boundary spanning, transformation, execution, and relation domains. And so these are really any competencies that individuals exhibit in their everyday work in being leaders. We decided to add something called enabling competency domains because we really felt that these competencies were competencies that more prepared and developed leaders to help them be effective in their context of work and help them to effectively lead. So again, action competencies help people help people in the context of their work, and enabling competencies enable them to do their work. And so these are the action competency domains. And then below it, which I guess folds up the action competency domains, these are the enabling competency domains. So I'll go over the competency domains specifically as well. And so first we have our boundary spanning domain, and this was our newer domain that we have added to the 3.0 model. And it was added in part to Gary Ukel's work. And what boundary spanning is optimizing relationship between a leader's span of control and the departments, organizations, communities, and/or broader networks within which it operates. So this includes community collaboration, organizational awareness, and relationship and network development. In the future of healthcare, we largely see organizations pushing to support the communities they serve, which is why this area is particularly important. And really, the work by Gary Ukel emphasized that leaders not only should be working within the context of the organization, but they should begin making collaborations and reaching out to other departments within the organization and perhaps even to other hospitals and health systems in the context of healthcare. So it's really just looking at a larger picture in the context of a leader's work. Next, in the action competency domain, we have our execution domain. The execution domain existed in the 2.1 model as well. So it's really just translating vision and strategy into action and to support optimal organizational performance. And this is our largest competency domain. We have accountability, achievement orientation, analytical thinking, our communication competencies, which, as I said, communication was broken down into skills 1 and 2 in this model, initiative, performance, measurement, process quality and improvement, and then project management. Previously, we had the people domain, which we just retitled to the relations domain, and all that is leading through example and actions to create an organizational climate that values employees from all backgrounds, provides a healthy and energizing environment where they work, and encourages everyone's ongoing development. And so this domain really has to do with the leader's interactions with the people around them. And finally, within the action competency domain, we have the transformation competencies. And so this has to do with creating and implementing inclusive change processes that support the improvement of health quality, efficiency, and access. So this includes competencies like change leadership, information seeking, innovation, and strategic orientation. And now part of what we've included in this 3.0 model is the enabling competency domains, which I'll go over. And the first one we have is health system awareness and business literacy. And really what this serves as is a flexible domain meant to house more of the technical competencies, which are really going to vary by organization. So this includes things like financial skills, human resource management, and information technology management. And again, they may be very specific to a manager and an organization. The next enabling competency domain that we have is self-awareness and self-development, which includes ongoing habits and actions to continuously improve oneself. And this includes self-awareness, self-confidence, and well-being. Now, well-being is our newly added competency as part of our future scan. And it really was included as a growing recognition that leaders have an essential role in fostering an environment of resilience. Burnout is a huge issue in healthcare right now, and it's something that we are looking to address. So in the future, that we hope that leaders are more inclined to also pay attention to well-being. And as a part of this, we also hope that the leaders in healthcare are demonstrating and modeling healthy habits to promote what they're trying to promote for their patients as well. And finally, underlying all of these enabling competencies are values. So understanding and utilizing personal, professional, and organizational values to guide decision-making. This includes our professional and social responsibility competency. This competency domain was added in part to UCL's work as well, who understood that values are really at the core of all of our decision-making and our leadership and should really be included in talking about leadership. And so again, similar to health systems awareness and business literacy, this is supposed to flexibly house different values for the individual and the different professional competencies or professional values that exist in an organization. It might differ by organizations. So that is an overview of the different model domains. And again, the primary difference from the original model moving from 3 domains to 7 domains. And this largely occurs because of the enabling competencies that distinguish themselves from not being in the context of in one's work, but enabling someone to do their work. Now, this is a list of the different domains and the competencies that fall under each. I know I mentioned what competencies fall under each, but this is just a visual for everyone. And this is also in the competency guidebook. And again, as I mentioned before, this brings us to the addition of new competencies. So we went from 26 to 28 competencies in the new model. As I mentioned prior, in the execution domain, we see the addition of communication skills 1 and 2. And then in the self-awareness and self-development domain, we see the addition of well-being. The other thing I'd like to mention on this competencies page is that in the self-development and competency domain, we have well-being. And with well-being, we do not yet have levels of proficiency. And what we're looking to do for that is continue to monitor the literature for areas we might be able to build out as to what a proficiency level for well-being looks like. We don't currently have a timeline for which this is going to be developed, but our team does continue to monitor this area. If anyone is interested in developing that area with us, we would be happy to welcome your support. We are looking to start a competency model users group, and this could be an excellent first project for a group like that to begin. And finally, getting to the most specific part of our model, we have the proficiency levels. And so within our model guidebook, we have each individual competency, where they fall within a domain, but we also have the levels of proficiency within each competency model. And so what proficiency levels are is it gives us behavioral statements which a leader can refer to see where they currently stand on that competency and where they can look to develop. And so the example I give for community collaboration is that someone with a level 1 might respond appropriately to community needs. They might follow through with being asked to deliver something to the community which they sit in, but someone at a level 5 might be actually serving the community and actually taking deliberate action to be a part of that community. And so you can see the differences between level 1 and a level 5 leader in this case. And just for reference, a level 1 leader would be the lowest in that competency, and a level 5 would be the highest proficiency level that you have. And each individual competency has a varying amount of proficiency levels, and that's just based on some of the research that we did and in seeing how a leader might develop through each of these levels. So finally, utilizing the 3.0 model. So what we're hoping happens is that the domains and the model that we've given, the 7 different domains, really starts as a starting point for prioritizing needs in an organization. So an organization might take a look at the model and say, you know, right now we're really good at relationship building with our employees, but we're not great at the execution portion. So from there, they might decide, okay, what competencies within execution do we need to improve on? What competencies within there do our leaders need to improve on? And so really using this model is making a targeted approach to your organization and its leadership development needs. Additionally, if you're trying to implement this model within your organization, the research really shows that the model needs to be communicated to all members within the organization. So this model can actually be used as a way to strategically align all leadership development initiatives within your organization. So for example, maybe you have a separate program for nurses than you do for physicians. What you can do is, even if you can't bring those training programs together, you can at least align them to a similar set of competencies so that everyone's speaking a common language about leadership within the organization. We also kind of see this model as neutral territory. So if no one really wishes to give up their current set of competencies or something that they're doing, they can at least align their competencies to somewhere in the framework, so that if nursing has a different set of competencies than the different physician departments, they're still able to say, well, this competency falls into an execution domain or a relations domain, so that they're at least having a common language around the framework that they sit in. Also, in part of development of this model, what we really hope to do is, when health systems have similar languages, we can more easily share best practices as well. And so as part of NCHL's work, we have a series of leadership excellence networks where we have leaders within our healthcare systems come together to talk about their best practices. And oftentimes, if we have a similar language around leadership, it's easier to discuss what exactly it is we are doing. And so in developing this model, we hope to give the field not only an evidence-based competency model, but one that can create a common language for all leaders to be talking about. Another thing as well that I'll mention briefly, and this comes from the article from the SIOP Task Force back in 2011, which aimed to highlight best practices in competency modeling, is that it's really important to strategically align competencies to your human resources system. So if you're using this for either performance management or development, you want to make sure that you are using the same competencies across each of those areas. And it's also useful to have information technology tools to set up a place where individuals can monitor their progress on competencies, so they're constantly using that language in their leadership as well. All right. So I went through that relatively quickly, but I'm going to take a look at the Q&A questions that are going on right now. But something that I want to mention is to get involved with NCHL, you can visit us at nchl.org. We do have our Human Capital Investment Conference coming up in November, and we'd love to have everyone join us if you would like to visit Chicago. As I mentioned before, we also have Bold 2020 coming up next year. This is a free tool that we give back to the field as a way to benchmark their leadership development practices. And so please be on the lookout for that. And we also have our Leadership Excellence Networks, which you can get involved in, which is a different professional networking group to talk about the different issues in healthcare leadership. And I will check on our Q&A. We had a question about explaining the boundary spanning domain better. And we go over this a little bit more in our Bridging Worldviews article, which is published in the Healthcare Management Review Journal. And really what boundary spanning is one's ability to reach outside of their department as a leader to other areas for collaboration. And so you might be looking within your department and saying, how can we make something more efficient within my department by either collaborating with other departments or collaborating with other health systems. And so really the goal is to optimize relationship within one's community to make someone a more effective leader. And so again, you have competencies like community collaboration, which involve giving back to the community you serve. I know that's something that Rush Medical Center is currently working on, and where they go into their communities and are trying to anchor themselves in that community and give back to their health as part of their greater mission and vision. We also have things like organizational awareness. So for a leader, not just to understand the problems in their department, but how do the problems in their department contribute to the health and the overall vitality of their entire organization. And then also relationship and network development. So one's ability to understand who are the key stakeholders within their healthcare sector and who are the people that they should know and be reaching out to and making collaborations with to improve their overall reach as a leader. And so boundary spanning is basically our collaborative domain that involves moving beyond the context of one's work and into other areas of either the organization or even other healthcare systems. Does that clarify the original question, hopefully? If not, we can just chat me and I'll try to explain it better here or offline.
Hi, this is Joyce Amwenio with NCHL. I could just give some historical context. I'm familiar with some organizations taking the competencies and the levels to and rewording them in order to fit into some performance management scales. I think some of the difficulty sometimes is the scoring of those within the performance management context versus within a context of like a 360 and so on. So the organizations that have worked to do that have kind of had worked through some of the issues around because all of these are very positive as well. So these are, you know, of scaling those or creating scales that properly measure within a performance management system, unlike what you might see in a 360, where you're looking at, do you see these behaviors and these characteristics? Do you not see them? And so that plays out a little differently in performance management. I hope that helps answer the question.
And just so everyone knows, because I don't know if everyone can see the Q&A, the original question was, have we seen these competencies be a part of performance appraisals, and what has been the reported experience? And then the other question was, is this model applied to all levels of leadership? And, I see, it's leaders of the self. So it is applied to all levels of leadership in the sense that we've interviewed everyone from early career risk to CEOs. So it does apply to a hierarchy within an organization. And so that's the primary levels that we're referring to when we say it applies to all levels of leadership. Do we have any other questions? If anyone is interested in the competency model user group, because I do see someone is interested, you can feel free to reach out to me and we can touch base offline. If anyone wants to comment in the chat or in the Q&A, I can pull anyone that says that they're interested in that, and we can start getting a listserv together and begin talking about that. questions does anyone else have? You can feel free to drop it in the Q&A, or I also have the chat open as well. I did get a question in the chat. Are there any assessment tools in development based on the 3.0? Here at NCHL, we have actually, we are about to launch, and we have developed a physician-specific 360 for physician leaders to use. And so that is right now for our Physician Leadership Development Council, but we are looking for organizations to collaborate. So if you're interested, you can feel free to email me, and we can potentially work you into using that tool as well. And so that's something that we've recently developed as of February. And are the slides available? I can make the slides available. This video will be included on our public YouTube channel. And after this call, an email will be sent out with the YouTube channel link where you can find it once it's uploaded. But I can also make sure that the slides are sent out to all of our attendees today. I have a question on where we can get the model itself. I can also send this in a link following this webinar as well. But if you go to the NCHL website, there should be a link to request the model. Once you request the model, it'll make you fill out a short survey just asking how you intend to use the model, and the NCHL team will email it to you following you filling out that survey. We just like to keep track of who is using the model at any given time, just so we have a gauge on how much we're impacting the field and who is using it. I was asked to describe the Physician Leadership Competency Model, and so what we currently did is we took a set of competencies from the 3.0 model that I've presented here today, and what we did was we originally did behavioral event interviews with physician leaders within the field, and based on that research, we took which competencies the high performers most often exhibited and used those specific competencies within the 360. So I believe it's 10 different competencies within the 360 that are assessed, and the 360 asks individuals where they feel that person is on that given competency. So whether or not they exceed expectations or whether or not they need to improve that competency. And so it is based on research, and it is based on the distinguishing competencies for physicians within the context of the research that we did in redeveloping the 3.0 model. And anyone interested in that, I'm also happy to touch base offline about that. I worked on developing that as well, and so we might be able to set up a call and go over what the tool looks like too. Thank you to everyone for joining the call today, and we hope this was useful in further understanding our model. I know I didn't get into the specific competencies, but if you go to our website and request the model, we hope that our competency guidebook is a very useful tool for everyone to use that gives further definitions of the competencies themselves and the proficiency levels within each of those competencies. And again, very happy to chat offline about the competency model and how you might want to use it within your organization. And anyone interested in a competency model users group, please feel free to email me, and I'll make sure to touch base with you offline. Thanks, everyone.